episode is very special. It's about inhaled insulin, and yet in India it is to be launched. And for today's program, we have Ms. Ginger Vieira, who is from USA. And our today's moderator is Dr. Bharat Sabu. He's from Indore, Madhya Pradesh. And he is also the mentor of D Genius now. So hand over to you, Dr. Bharat Sabu.
Thank you, Dr. Rutul. First of all, I would like to congratulate you and D Genius, all the members of D Genius, because D Genius is a community of young, upcoming diabetologists. Most are established now, not upcoming. But this is a branch where the young doctors are doing their bit for the development of diabetes technology, newer advances in diabetes, and making lives better for the patient all around the world, not only in India itself. So today in this sequence, we have along with us Ms. Ginger Vieira from USA, along with our 4 eminent panelists. And as you all know, Dr. Rutul, who is the convener of D Genius and who is actually national convener for D Genius Group. So our first panelist is Dr. Ashwin Mukandan from Calicut, who is a consultant diabetologist over there. Then we have Dr. Dhruvi Hasnani from Ahmedabad, who is a diabetologist over there. Dr. Amit Dey from Kolkata, a very active member of D Genius, and Dr. Anushri Mehta from Mumbai. So we have all these 4 eminent panelists along with our convener, and we have none other than Ginger Vieira, who has lots of experience with this newer sort of insulin for Indian patient subtypes. She is from USA, and she will be today sharing all her experiences regarding this unique molecule which she is using. So I think without wasting much of the time, we should begin with Ginger. So Ginger, can we know how long you are being a diabetic?
Good morning or good evening to those of you in India. I have lived with type 1 diabetes for 25 years. I was diagnosed at 13 years old, and I am 37 today.
Great. Wonderful. So when you started using Afrezza in this 25-year-old journey?
When did I start? I started using Afrezza only 2 years ago, I think now. So not long. And I have to tell you, I would be heartbroken if it was taken from me. If I had to go back to just using injected insulin, I would be so mad because I love what Afrezza has done for my day-to-day life in managing type 1.
So as you told, it has changed your life. So it must have been a very, very difficult switch for you mentally.
Well, let me explain how I managed my diabetes before. So I had used an insulin pump for the first 10 years of living with type 1 diabetes. So until about my early 20s. And then I got really tired of the skin issues and sight failures. And I had a DKA episode, diabetes ketoacidosis, because of an insulin pump failure. And it just made me really just sick of insulin pumps. So then I started doing multiple daily injections. So I used a long-acting insulin and then a rapid-acting Novolog. And I did that for many years. And I was able, as I got older and the more years I had under my belt, and then CGMs were introduced, right? So I had a Dexcom or a Freestyle Libre throughout the next 10 years. And I was able to maintain an A1C in the high 5s and the low 6s, doing entirely injections. But, that meant a lot of injections every day, like sometimes maybe 10 injections, because in order to achieve that level of A1C, you have to take a lot of teeny injections, right? Like little adjustments to keep yourself in the low 100s. So it was a lot of work, right? And I didn't want to use an insulin pump. So those were kind of the 2 options in today's diabetes management world until Afrezza came along. So when I started using Afrezza, I was doing great with injections, one could say, right? But the amount of work that was going into it's something everyone has to deal with. How long it takes for an injection of Novolog to kick in when you take it, right? How long it's in your system for. So how long you have to worry about insulin on board. If I eat lunch at 12 o'clock and I want to walk my dog at 2 or 3 o'clock, I have to worry about going low if I use Novolog or Humalog to cover the insulin for my lunch, right? With Afrezza, you don't have to worry about that nearly as much because it is in and out of your system so fast. So I'll take a break on my rant right there and see if you have a question.
This was really fabulous. So I would like to have it from Dr. Amit. So if someone wants to switch from injectable to Afrezza, what is the science behind it? How they should do it?
Yeah, so thank you for that question. First of all, congratulations, the team DGenius, for coming up with this fantastic idea of discussing something very new, which is on the basket for us. And a warm welcome to Ginger, to share your user experience live with all of us. It's a fantastic experience for all of us hearing from you. So, what the literature is telling us, and I've been reading the literature of this inhaled insulin, is that if an individual needs to be switched over from the injectable to the nasal insulin, the total dose that would be required would be 1.5 times than what was required in the injectable dose. If it's an insulin naive patient, then you would probably want to start with the 4 units, with mealtime. Now, here I also want to tell our viewers that what we are talking about is inhaled insulin, which is the dry powdered form of the monomeric human insulin. So it's an ultra fast acting, in the ultra fast acting mode, it will act. So the starting dose is going to be 4 units in the mealtime for any individual who is starting insulin for the first time. If somebody is already taking injectable insulin, then you would probably want to titrate from 4 units upwards, and the total dose would be 1.5 times than what the patient was requiring in terms of injectable insulin. Now, there's also one more thing here I would first mention, and then we can take the feedback from Ginger, how she is titrating it, is that this particular inhaled insulin comes in cartridges of 4, 8, 12, and so on. So you are probably looking at titrating from 4 upward onwards, and then you can set the cartridges according to the need of the mealtime insulin. So with this brief overview, I would now want to ask Ginger that, what was her experience when she switched over into inhaled insulin, and how has she been, using it to titrate, even for the matter that correction bolus? Ginger?
Sure. So that was a great overview. Let's start with how inhaled insulin works, because part of what keeps people with type 1 from trying it is the dosing, because it's so different than Novolog or Humalog, and it works so differently that it's very hard to actually give a perfect conversion. So when you take a dose, let's say 1 unit of Humalog or Novolog injectable rapid-acting insulin, it doesn't really start affecting your blood sugar for at least 30 to 45 minutes, and it stays in your blood sugar for at least 4 hours. When you take a dose of Afrezza, let's say the smallest dose, which is the 4 cartridge, it starts working within 2.5 minutes, and you can visibly see it on your CGM affecting your blood sugar within 15 minutes. And then it's out of your system about an hour after taking it. And there is like a little tail, that when they're watching it in your bloodstream in their research, that it could be up to 90 minutes, but you really don't see the impact after 60 minutes. The larger doses, the 8 and the 12, those have a longer time on board. It's more like 90 minutes to 2 hours, but they start working just as fast. So that dosing really scares people with type 1, because when you're taking injections or using an insulin pump, you have to be so precise when you take your dose, right? And if you're a half unit or a unit over and you're highly sensitive to insulin like I am, then you're low and your hour is ruined, your afternoon is ruined, right? It's very disruptive. Or if you underdose, then you're high and it takes hours to get back on track because injectable insulin is so slow. So what I love about Afrezza is that once you get past that first month, I would say, of learning how to use it, and you should expect it to be a bumpy month because this is a completely different way of taking insulin, a completely different way of managing your blood sugar. Once you get past that first month, it really is so much easier to dose for meals, because I like to describe it as when you're taking injectable insulin. It's like a hammer on the meal. You have to hit it right on the head. It's very exact. It's this boom, right? And if you miss, it's like boom in the wrong place, right? Either direction. With Afrezza, it's like this big soft blanket you kind of throw over the meal. And if you didn't cover the whole bed with the blanket, then you just throw another blanket on. And it's like not a big deal. It's like this lower commitment. And so let's say I eat an apple with some cashews for lunch. I'll take an 8.
That's a wonderful explanation, Ginger.
Thank you.
In continuation to this, a question stems out that what needs to be done with the basal if I am on Afrezza, suppose?
Sure. Yeah. So your basal will...
Sorry, just wait. This is for Dhruvi. Let Dhruvi answer this.
Oh, sorry. Go ahead.
Thank you. Thank you so much. It's such a wonderful interaction that is going on, and we all love to hear the first-hand experience of somebody taking Afrezza. We're also excited, but Afrezza is equivalent to the prandial insulins. Somebody living with type 1 diabetes still needs to take the basal dosage, and all the clinical trial data is still putting Afrezza as equivalent to a prandial insulin. So you cannot get rid of the basal insulin as of yet. And I think Ginger would still be taking the basal insulin. So that's the answer for all the viewers who are listening to us, that Afrezza, a nasal insulin, a powdered format, like Dr. Amit said, can be used for all of your prandial needs.
So as Dr. Dhruvi, you have told this is a powder form, and Ginger told it needs to be inhaled. My question to Dr. Ashwin is, so can it be taken in open spaces? Because a patient may need to take it in open spaces, which is full of dust, smoke, like in India. So what is your take on it?
Okay, thank you so for asking. I think it's quite open. The answer is quite easy. Because if you can't take it in an open space, it's not convenient. If you had to go inside a room to take a convenient insulin like Afrezza, so the obvious answer is yes, you can take it in any place. I think Ginger is the person who can add on to that, who has multiple experiences on this molecule from her behalf. Thank you for asking, sir.
I would say it's actually easier to take than an injection, because I could do it while holding a child in one arm, right? I can do it in the middle of an airplane. I don't need to try to get my sleeve down in order to find skin for my injection. It does have a little bit of a backdraft after you take it. So it's like this little, it looks like smoke, but it's not. It's just like kind of this powder moment of fog. And I go like that sometimes. And if my nose is a little moist, it will turn the hairs in my nose white, even though it is inhaled through your mouth. So it's inhaled through your mouth like this. And that's it. That's all you do. It's very fast and easy.
Wonderful. So question, one of viewers have asked, Anushri, can you answer this? What about smoking? Because a lot of people smoke, and if they want to take Afrezza, what does the guideline say about smoking and all that?
So actually, based on the literature, Afrezza is not recommended for people who smoke. And even those who are smoking in the past, they should have quit smoking for at least 6 months before we can consider starting Afrezza. What is very important is that people who have history of smoking, and in general everybody, we have to do a lung function test before we start or recommend Afrezza to such patients, because it may affect the lung function, and Afrezza is known to cause an acute bronchospasm. So especially if they have hyperreactive bronchi, then we have to be very careful before initiating, and probably, be a little bit more cautious or warn the patient about the symptoms while initiating.
That's a very vital piece of information. And Dr. Tutul, in continuation to that, are there any drug-to-drug interactions or any insulin-to-insulin interaction with Afrezza to any other class of drug?
For people with asthma or anyone with, yeah. Can you speak on that? Anyone with lung
you
conditions?
may answer, please.
Oh, if you have any pre-existing lung conditions, then you might not be a candidate, but there are people with asthma who can use it. And the lung function testing, they've documented that there's a 3.5% decrease in lung function while using Afrezza, but when you stop using Afrezza, it goes right back up. So it's not damaging your lungs. It's been deemed safe, and the bronchial spasms is a rare side effect. That's certainly not something I've experienced in 2 years of using it. I don't know anyone who has. So these are all rare things for sure.
Dr. Utul?
Yes, I'm here.
So any interaction you have read about or science mentions it?
No, rightly said by Ginger. I guess most of the drugs, they don't have interaction, but I didn't go through all the guidelines. I don't know about the patients who has bronchial asthma, who are taking already another inhaled drugs. So I don't know about that, and I guess it does not interact with anything. As rightly said by Ginger, most of the patients who are taking Afrezza, they might have some other pulmonary issues, but they are taking it safely, as it does not reduce pulmonary function.
Great. So Ginger, one your personal experience, you are taking Afrezza since past 2 years. Did any point of time you had any sort of hypoglycemia with Afrezza?
Oh, you can go low with any type of insulin if you take it wrong. Of course, yes. So when you are first starting out using Afrezza, it's very important to realize that you're probably going to use it wrong at some point because it's so fast. You're not used to how fast it is. So if you try to pre-bolus your insulin for a meal with Afrezza, you will go low. So when you're taking an injection of insulin for a meal, you are supposed to pre-bolus, right? Take the insulin at least 15 minutes before you start eating, because it's so slow. You're trying to get it to meet the time of digestion. Afrezza is so fast that it will start working too soon. So I don't pre-bolus for my meals. If anything, sometimes I wait till I'm done eating before I start dosing. And when you're correcting a high blood sugar, an awesome thing about Afrezza is I could have a blood sugar as high as 250, for example. And if I take a dose of Afrezza, I can be down at 100 within 1 hour, and I don't crash because it's already clearing my system. So it brings me down rapidly, and then it's out of your system rapidly. But if you take too much of any type of insulin, you can go low.
So, Dr. Amit, is there any specific data with Afrezza vis-a-vis other insulin regarding hypoglycemia? It's very fast acting.
Yeah, so in the clinical trials, there were a fair number of hypoglycemia that was told about in the trial data, which I read in the literature of the Afrezza. Rightly said by Ginger that, because this is a very fast acting insulin, so the incidences of hypoglycemia is going to be there. So what we understand from hearing from her also is that the timing of the insulin is going to be very, very important. Now, I just want to also learn here from Ginger one very important thing. When you have been getting incidences of hypoglycemia, how exactly are you titrating the dose? Because it comes in the format of the 4 and the 8 and the 12 cartridges. So how are you actually titrating your dose to come to the exact accurate dose? That's one question. And the second is, what about the correction bolus that you can take, after the meal? So, how quickly does it bring it down? And is there an incidence of hypoglycemia when you're taking an extra dose, as a correction bolus? Your experience, share, Ginger.
Sure, those are great questions. So the first question with titrating, really, when you start Afrezza, you should have 4s and 8s. And if someone is very insulin resistant, right, or just a very large man, for example, who needs large doses of insulin, they would likely also need 12s within their prescription. So I get 4s and 8s in my prescription. They come together, the combo pack. And some meals I need 8 units, some meals I need 4, some meals I need 8 unit, the green cartridge, and then an hour later I might need another if I'm having a really high carb indulgent meal, right? Or if I'm eating a big bowl of rice. That's a lot of starch, but I don't want all the insulin all at the same time. So one of the drawbacks of Afrezza for some people is that you do have to take pretty frequently what's called a follow-up dose. So if my meal digests over the course of 3-4 hours, I would normally take 1 injection of insulin for that, right? Most meals don't digest within 1 hour. So I know about an hour after taking Afrezza for my food to keep an eye on my CGM and see if my blood sugar is trending up, then I take another dose of Afrezza to cover the rest of the digestion. The great thing about that is that, let's say I want to also walk my dog an hour after, right? Or I want to go to the gym and exercise. Instead of taking another 8, I could take a 4. So I'm only taking half the insulin I need for the second part of digesting that meal. And I won't go low because I'm reducing my insulin dose, even though I'm also exercising. So it's just as, you have to be just as flexible as you do with injectable insulin, but your options are fewer. So it's actually less work. It's less confusing. And again, you're treating it with a blanket instead of a hammer. So I don't know if that fully answers your question or if that kind of spurs on another.
No, it's perfectly answered. So Dhruvi, because it's a very fast acting insulin, so would any change in guidelines or treatment for hypoglycemia would exist for Afrezza as compared to other insulin?
The current data is saying that the treatment for hypoglycemia of a person with type 1 diabetes and taking Afrezza is the same as any other insulins. The 15-15-15 rule, taking a 15 grams of fast-acting carbohydrates, waiting for 15 minutes, checking your sugars again. If they are low, recorrect and do the whole process again. So I'm not sure how frequent are the hypoglycemias, but Ginger did elucidate that, it's quite common. And just like any other insulins, I think monitoring should be the real basic thing, the basic principle that goes along with taking any sort of insulins.
Dr. Amit, you want to
I'd
say?
love to.
Yeah.
Go ahead.
I just want to summarize one point for our viewers, which Ginger mentioned. So one thing we can understand here that if you are using an inhaled insulin, then CGM monitoring is very important, because you got to titrate the dose based on the CGM monitoring. So that's something that should go along with the inhaled insulin. And the second thing, your post-meal correction bolus would also largely depend upon the type of meal that you're having. So if you're having a complex carbohydrate that would get digested over a longer period of times, then you would require a correction bolus at the right time. So I think these are the two very important points I could note from Ginger's.
Very true, because it's a very fast acting insulin.
Yes.
You need to monitor it also very, very meticulously.
I would love to add to that, actually. So I think using a CGM when you use Afrezza is critical, because your blood sugar can change so quickly. So let's say I didn't take a follow-up dose, and I know even with an apple and nuts, right? Pretty simple meal. An apple is not digested fully in 1 hour. So I absolutely need additional insulin. But if I missed it, because that first dose clears my system so quickly, your blood sugar can rise very quickly if you don't take another dose. So you have to stay on top of it. But as soon as you see it rising, it works so quickly that it doesn't feel like I definitely have far fewer lows using Afrezza than I did and I almost forget how I'm very active. So, and I walk my dog twice a day, and then I exercise addition to that. And the amount of extra carbs or juice, right, or fast acting candy that I had to eat because I knew I had insulin on board in order to go on my dog walk was so much more now. I almost never have exercise low blood sugars because I know how much insulin is on board. And usually it's nothing because I time it for when the Afrezza has cleared my system, right? When you do have lows, what's really great is, let's say I took my Afrezza dose at 1 p.m. and I'm starting to go low at 1:45 p.m. I know that the Afrezza is going to be pretty much out of my system by 2 p.m., 15 minutes later. So I actually need far fewer carbohydrates to treat the low blood sugar. And I mean like 5 grams or just kind of waiting. And the blood sugar comes up far more easily. And a doctor described it to me, a doctor who likes Afrezza. A low blood sugar with Novolog or Humalog feels like a train coming at you. It just like takes you down and it takes forever to recover from. A low blood sugar with Afrezza, it can, if you really got too much, it can feel dramatic for a little bit, but it's over so much sooner because the insulin passes. And you also, because of that quick time frame, let's say my CGM says 85 with a slight slanted down arrow. But if I look at when I took that Afrezza dose and I know it's been nearly an hour, I know I'm not going to go low. And I don't have to worry about it because I know the biggest impact of that dose is practically cleared my system. So
Wonderful.
that it just eases the anxiety.
Great. It would be a real insight for our patients, actually. Thank you, Ginger, for this. So, Dr. Ashwin, now one question stems out of this, that what about our renal patients, those who are already on a low renal reserve? What does the science say about this for them?
Okay, sir. Great question. So to our viewers, put it in simple terms. If you have a kidney disease, usually we reduce the dose of your insulin, day-to-day insulin, because insulin is excreted through the kidneys and it stays in your system if the kidneys are not functioning properly. But in terms of Afrezza, it's so fast acting that there is no there is no impactful dose reduction required, since it's ultra short acting, as better than a Fiasp, I would say. But in case you're trying to take a booster dose, just like after an hour or so, because anything that goes into our blood system is going to be cleared by our kidneys, you have to be a little bit careful about the duration of action of Afrezza, since even though Ginger is saying 1 hour for her, the data says 90 minutes. And I think in renally compromised patients, it stays a little bit extra. So that's my answer for it, sir. If Ginger
Wonderful.
can.
Wonderful. Dr. Anushri, one more common issue, which is very common in India, and it is very particularly common in these days, throat infection. So what does the literature says? Does it mentions anything about throat infections and Afrezza?
So the literature doesn't talk about throat infections. It does talk about lung infections. And it says that during lung infections, we should not use Afrezza. But since we are talking about throat infections, I would like to divide the answer into a few points. So the first point is the blood sugar. Whenever any kind of infection is there, we are worried about the blood sugar. And since it is throat infection and Afrezza per se is absorbed through the lungs, so I don't really think that the absorption should be affected. But what is very important that the patients have to keep a watch on their blood sugars. And second part is that if they develop ketosis, then they should probably shift over to an injectable insulin, because Afrezza is not recommended to use during ketosis. I think Ginger will probably be able to give us an insight into that, right? The second part is, as I mentioned, that a lot of our patients they are normally okay, but during the throat infection, they develop bronchial hyperreactivity. Some of them have a wheeze. So I think we have to be especially careful in such patients, although I think we don't have any practical experience for me to comment on it. But based on the literature and the rare side effect of bronchospasm that can occur with the Afrezza, then probably in such patients, we have to be careful. But if they have if they have an LRTI, then definitely.
We would like to welcome Dr. Banshi Sabu, who has joined with us. Thank you, sir, for joining. Dr. Banshi Sabu, sir, is past president RSSDI and currently chair-elect for IDF Southeast Asia. Sir, we are talking about Afrezza, which is soon to be released in India. And we would like to have your insights on this molecule.
Most of our type 1 diabetic patients, particularly those who are, and other than type 1, who are on multiple daily insulin injection, the number of shots may be 4, 5, 6, and that's really challenging for type 1 or someone who is on multiple daily insulin injection. They are always looking for an alternate which can reduce their number of insulin injection, and that will make their life more convenient. So we know that Afrezza, a very short acting, which can be given in an inhaled insulin form, and a longer acting insulin can be given once in a day. And now, we are waiting for once in a week, as I have been also part of the clinical trial. And next week onward, we are also starting in India the advisory board meetings for the High Court, which we are looking for. So probably life for those patients who are on multiple daily insulin injection, they could be on once in a week a very long acting basal insulin and multiple shots of Afrezza or a inhaled insulin as and when required, or also for their regular before breakfast, before lunch, and before dinner. The correction dose will become better. So now everything is becoming, non-invasive glucose monitoring. For 14 days, one prick. Simultaneously, you are taking inhaled insulin, and once in a week, a long-acting insulin. So you can see that how many number of pricks can be significantly reduced in a type 1. So this is what the science is, and the technology is going to give benefit to our patients. Definitely, any new thing comes or any technology, it will come with cost, but still we have a lot of patients in India who can afford this newer technology.
Thank you, sir. Wonderful insights. So, taking it forward, Dr. Rutul, what is your take on other infections apart from lung infection, like Dr. Anushri was talking about? What about the other infection if patient is having? What is the recommendations for this?
I think apart from lung infection, there is no clear guidelines for Afrezza that it may cause or it may increase any kind of infection due to the usage of Afrezza. And I guess Ginger would be the better person to talk about and her experience as well about the same thing.
Sure. I'd love to touch on two things that you all just brought up. So first, of course, we always need that basal insulin, but I want to add that I still use injectable rapid acting insulin also. And here's why. Let's say I'm eating pizza, really slow digesting, takes hours to digest, and then I want to go to bed. I don't want to wake up every hour and take follow-up doses of Afrezza, right? So I will take Afrezza maybe when I sit down to start eating the pizza for that first dose to cover that first initial impact on my blood sugar. But then I'll also take a small dose of Novolog before going to bed to cover the later digestion of that meal. So any of those long digesting meals, I might choose to use a little Novolog as well. And then also, if I want to, have you heard of Dawn phenomenon? Is that a phrase in India? Okay. So that's kind of that long drawn out impact and from morning hormones on my blood sugar. Afrezza is a little bit too fast sometimes to affect that. And the dose is too large, even the smallest dose. So I'll take just a half unit of Novolog just to help keep that Dawn phenomenon hormone spike in my, stay in my target range. When people, in terms of your throat, when people do start using Afrezza, many notice a cough. And I did have a cough for the first month or two, maybe 3 months, just not all the time, but coughing after you take a dose. And it's just kind of this light cough, nothing significant. But that does go away for most people, and most people in groups on Facebook that I'm part of share that theirs goes away. And when I've been sick, though, like I did have COVID last year, and I was relatively fine. It was not fun, but I wasn't in the hospital. But Afrezza was not great to use during the first few intense days of COVID. And then also, you mentioned, Dr. Anshri, that it's not recommended for treating diabetic ketoacidosis. I would 100% support that because it's, again, I described it as a light blanket, right? It's just in and out too fast to deal with when your blood sugar when you're in DKA, you need a lot of insulin to help get out of that. And Afrezza just isn't appropriate. It just doesn't function in a way that's going to help treat DKA. So I would definitely recommend not trying to use Afrezza in those moments. And then in terms of the impact, when I switched from using Afrezza for most of my daily meals and corrections, I did need a slight increase in my long-acting background basal insulin, and that's not uncommon. And by slight, I mean like 5% or 10% increase in my dose, and that is well known to the makers of Afrezza, and it's common. And it's because you don't have all that Novolog or Humalog on board all the time, right? Because it's practically always on board if you're eating every 4 to 5 hours. So you need a little more basal to help fill in what you were getting from your meal boluses.
Wonderfully explained. So, Dr. Ruvi, we have a question. One of our viewers is asking that I am a type 1 diabetic patient, and can I take this insulin during school hours? And when I come back home, can I take my conventional insulin? So how feasible and practical it looks to you?
So it's amazing how we can set this inhalable insulin in between the injectables. Of course, it would require a lot of titration. It would require a lot of monitoring, but logically, it is a possible yes as an answer, a positive answer, that during the school hours, the child can take the inhaled insulin, and when they come back home, they can switch back to something that they are still comfortable taking. Let me put it like that. That they know how the injectable is going to work. They can predict how the dosage is going to affect their sugar levels. So yes, you can fit in the inhaled insulin in between the other injectables. As of now, that's the answer.
Okay. So Ginger, we have one question for you also, and it's a very valid question because we are very new to this molecule. So what does the device look like and how we refill it? Can you just show it to us?
Sure. It's very simple. There's no batteries, there's no electricity. This is just plastic, totally plastic. And then the cartridges come, so a full sheet looks like this. And you just break them apart and you take out a cartridge and it pops right in there. And then when you close it, it's actually pushing it back. So it's opening the cartridge on the top. So if I were to take this back out and go like that, dump it upside down, the powder would come out the top a little bit. So now this cartridge is open. There's a little window on the top here where it's coming out when you inhale it. You go like that. I'm not going to inhale this because I don't need insulin right now. But I'll take it out and do a demonstration. And that's it. It's very fast. And then this is garbage, basically. Yeah,
that's too good.
So it's really easy, isn't it?
Very easy. It would be very hard to screw this up.
Great. And we have one question, Dr. Amit. Can you?
So we have few questions on Facebook Live. There, one of the question is that what should be the minimum age of the medicine to take? What could be the age limit, lower age limit for this Afrezza?
Dr. Amit?
Or Ginger, if you know, if she can answer, or Dr. Amit?
In the U.S., it's currently in the U.S. approved in people 18 and older, and that's not because it's not safe for children. They just have to do the study on children, and they are doing it right now. And so I expect in the next couple of years it will be approved for children as well.
Great.
Yeah, and the same goes for also the use in pregnancy and lactation, because at the moment it is not to be used in pregnancy and in lactating mothers. Most probably there are some studies carried out in the rat models, and it's been found that besides the drug, the carrier is also secreted in the breast milk. So that should not be used. And I would quote what FDA says, that in terms of pregnancy, it should not be used unless the potential benefit outweighs the potential risks of using it. So I think we are at a position of exploring this molecule of inhaled insulin in the common category of people. So you talk about the younger age group and in pregnancy and in lactation. I think going down the line, we will probably be having some research, as Ginger said. It will be studied on the younger ones, and probably rightly approvals will come thereafter.
So one another question is there on Facebook Live, is that any adverse effects on nostrils?
No.
On nostrils? No.
Yeah. Right.
The logically, since
it
it's
doesn't
been taken through the mouth, I don't think
the mouth.
It's a new molecule, so people don't know how it is taken.
Yeah, and I want to add that it doesn't have a taste. It doesn't have a smell. You don't feel it hitting your throat. It's not cold. It's not hot. It feels like nothing. If I did have a really dry throat, like let's say I ran 3 miles and then I tried to take a dose of Afrezza without drinking a little bit of water first, because my mouth would be dry from the exercise, I wouldn't recommend that, and you will cough, right? So you should take a sip of water before if you're not already.
And what about geriatric patients?
Yeah. So yeah, please go ahead.
Yes, please.
Rohi, please.
Go ahead, Dr. Devi. Please go ahead.
I've just been reading the data. It's approved in geriatric patients and type 2 diabetic as well. And it's showing that it's completely safe. The data as of now is showing the efficacy and safety of Afrezza both in adults
Dr.
above
Amit,
18
please
years.
mute yourself. Please mute yourself.
Durvi, actually, I have done the clinical trial of this,
Yes.
and in that the group was between 18 to 65. And the challenge is not the safety issue, but the challenge was, how they will take it. I mean, that's more difficult for them to take it. That was more bigger challenge. So I just wanted to understand that is there any clinical trial which will happen above the age of 65 and then it goes more than age of 75, 80, 85. Then the issues related to chronic lung disease and COPD and history of fibrosis. And in India, when many patients are having history of tuberculosis. So these are also some of the challenges. But we have done for 12 patients in our center with Afrezza. A study was conducted in India with the help of CIPLA, and we have done. And we asked actually one more study from the company that we should do with the continuous glucose monitoring because these were the type 1 diabetes patients. But it was with self-monitoring, but the results were fantastic.
So the only trials that are coming up on the internet right now are the Affinity 1, the Affinity 2 trials, and these are all in type 2 diabetes with a 6-week run-in period, and none of them are clearly mentioning the age as of now. That's what I'm looking up. If somebody knows about it, we can discuss that.
Great. And Ginger, we just want to know from you how your quality of life has changed in past 2 years since you are on Afrezza.
I would say that honestly, I spend a lot less time worrying about lows. I spend a lot less time treating lows. I can exercise more spontaneously, more easily. I don't do you have the term rage bolus in India, where someone wants to correct the high blood sugar so fast, so they take a really big dose of insulin but it doesn't work any faster when it's injectable insulin, no matter how much you take, right? You still have to sit there and wait hours. Afrezza kind of cures rage bolusing because it does work so fast. So I can take a normal dose of Afrezza and still get back down into my target range quickly. So for me, it eases a lot of the anxiety and stress that comes with using injectable insulin as your primary rapid acting insulin.
Can I say something?
Yeah, Anushri, please go ahead.
So from whatever Ginger is saying, what I'm gathering is that the biggest advantage of Afrezza, probably because of the way that we are taking it, is the short acting, the rapid onset of action, and the duration is very short. And that is the biggest advantage that she's noticing in terms of managing her type 1 diabetes, which I think our viewers should take back, that the biggest advantage of Afrezza is the short onset of action and the short duration of action.
So it's a beautiful...
And not only the modality.
A quick correction is what you can...
Yes.
So what about exercise? Does exercise impacts absorption or something like that, Ginger?
Well, exercise increases the absorption of any type of insulin, right? So, and I actually just published a book on exercising with type 1 diabetes. This is available all over the world on Amazon. I published this about a month ago because exercise is something I'm very passionate about teaching people with type 1 because it is very complicated and many people get discouraged because they go low, right? And it's so easy to have low blood sugars when you're exercising with injectable rapid acting insulin because it's always on board. It's just on board so long, right? So with Afrezza, if I took an 8 for my lunch and immediately went and walked my dog for 2 miles, my risk of going low is plenty, right? It's just like if I'd taken rapid acting because I'm exercising with a lot of insulin on board active in my system. But because Afrezza is out of your system so quickly, it's easier to time your exercise for when you don't have a lot of rapid acting insulin on board. And that is really what I teach in this book.
Yeah, Dhruvi, please.
So I have a very sort of a personal question. We have 2 people on board here with type 1 diabetes, one taking injectable, and, Ginger has tried the inhaled insulin. How is this shift, affecting the mental health? How do you? There might be some people who do not want to bring those changes. Like if I would be somebody living with type 1 diabetes, if I am in a good place with my MDIs or with my pump, why should I try something which is newer, just on the block, and something that requires, again, a rigorous change in my life pattern, something that is asking me to do a continuous glucose monitoring again? It is a lot of work, and if I am quite stable with my current position, why would I go for Afrezza? If all our viewers are listening to you, Ginger, just pointed out, not the pharmacokinetics, not but the personal experience.
Many people with type 1 in the US who have access to Afrezza immediately say, no way, I don't need that. That wouldn't work for me. And it's because they don't understand it, right? But also people are afraid of change. It happens to all of us. I don't want a new cell phone. I don't have to learn a whole new phone, right?
Exactly.
But even someone who is doing well with rapid acting MDI injectable insulin, it's still a lot of work. And you're still you might be used to how much work it is, right? Because you don't have a choice. But, and I was doing well on MDI. I had I had 2 pregnancies. I had an A1C in the 5s and 6s. And I was thriving. I'm an athlete and everything. So it simplifies things that come with it doesn't matter how well you're doing in type 1 diabetes. You're still working really hard, right? And I feel that Afrezza simplifies and makes certain parts of type 1 diabetes easier because of how it works so differently than injectable insulin.
Well, thank you. Thank you for the answer.
Can I just ask one question to Ginger, Dr. Bharat?
Please go ahead.
Yeah. So, I was just thinking, Ginger, that since Afrezza is a mealtime insulin, and we have discussed about the way it works, the pharmacokinetics, you'll always be requiring this basal insulin along with this inhaled insulin. So, how would you divide the dose of the basal insulin and the inhaled insulin? Keeping 2 things in mind. One is, of course, the total dose of the inhaled insulin would probably be twice as the pre-meal MDI dose that you were taking. But at the same time, you're looking at a very ultra fast acting insulin. So would it actually require lesser amount of total dose of the, mealtime insulin? So how is your experience in dividing the dose amongst the basal and the inhaled insulin? Your thoughts?
Sure. My basal insulin dose changed just a little bit when I started using Afrezza. I was taking like 10 units of Lantus insulin a day from my background insulin. And I went up to 12 units, I believe, in that first year. I have since started taking metformin. So my basal insulin dose is back down to 9-10 units a day. But that's a whole nother topic. But so it was just a slight change. But when people try to convert the units of Afrezza to units of Novolog or Humalog, it just doesn't work that way. Because if I did the math that mankind has to give you in order to help you get started, it would never work that way for me. If I ate a salad with steak on it and some veggies and very, very low carb, right? I might take 1 unit of Novolog for that. And the math that they tell you of Afrezza is that Afrezza is like up to 4 units of insulin for a 4-unit cartridge, this blue cartridge. I would take 1 of these for the low carb steak salad. So that if I took up to 4 units of Novolog for a steak salad, I would have a terrible low blood sugar. So it really, again, it can't be converted perfectly. And my Lantus dose, I don't split it. I just take it once a day, as usual. I didn't change anything about how I take my long-acting basal insulin. Does that answer your question?
So I have one question. Is it approved by FDA for type 1 diabetics? as Dr. Anushri was the other day, she was discussing with me that it is only approved for type 2 diabetes.
No, it is approved for type 1. It is approved for type 1, and that's the trial that I was telling you about.
Says that it is approved. But I think it received approval for
type 1.
Sorry. Yeah,
Maybe.
it received approval for type 2 earlier. Yeah.
Yes.
Yeah.
Earlier, there was this Exubera by the Pfizer people. Right. They discontinued that, and for Afrezza, they did a trial with adult type 2s, and then with adult type 1s, and now it is yes, Dr. Mukherjee wanted to add.
Sorry, you continue. I'll ask another question after following your.
Sure.
Sorry.
Dr. Dhruvi, please.
Yes, so it is approved in adult type 1s right now as a prandial insulin along with a basal insulin. And the trial's name is, I guess, the type 1 arm. Let me give me 1 second and I'll tell you. Till then, you may ask your question.
Till that time, I just want to ask
Affinity 1 trial is the type 1 adult trial. It was a 24-week open-label non-inferiority study to compare the efficacy of the inhaler in type 1 diabetics with an A1C between 7.5 to 10.
So I just want to take a quick question which came on the Facebook Live, and it has been asked by a viewer. That what about the storage and shelf life, Ginger?
It's very similar to injectable insulin. I store my extra cartridges in the fridge. It does take up a lot more space than injectable insulin because I get a month's worth is like, 12 of these things, right? So they're stacked up in my fridge. But I take out kind of what I might use, whatever I can fit basically in here. I bought this pencil case on Amazon because I can store 2 packs. So I can store one of these of 8s and one of these of 4s in here. And it's room temperature, right? So I wouldn't want to leave it in a hot car or on a hot beach or out in the freezing winter of Vermont cold. So you need to be thoughtful of the temperature, just like with injectable insulin.
Great. And what would be the cost in India? Dr. Amit, do you have any idea, or any of our panelists has any idea about it?
I think that's a trick question that's going to go to all of us. What should be the cost? And if I have to put my thoughts into it, I would say to start with, it's got to be affordable and accessible. But again, when you talk about affordability, we are looking at a diverse population in India. So, you just can't draw a benchmark line that what is affordable to one might not be affordable to the other. So, you got to look at 2 aspects. One is, of course, what it is replacing. So the convenience of use, that's very important. And the second thing is also the total dose of insulin. Ginger's experience is one. Literature says that, it needs to get probably the dose that would be required is going to be double. So all those factors needs to be kept in mind while deciding upon the cost. I think those are my thoughts, but I would love to hear other panelists' thought, like what could be the ideal cost.
So a company in India is coming out with Afrezza, and if you Google Afrezza in India, I don't know how is the cost coming out, but it does say that the vials in New Delhi are available for something around 8K. Just Google it up and you will find that.
Great.
I don't know how reliable it is, because that's the first thing. The reliability is, of course, questionable because, the DCGI approval and all. So, but an Indian company is coming up. Let's not name it.
Yeah, I think it's
Ashwin, you wanted to ask a question because we are really running short of time, and this is a new kid in the blog, and it's so exciting.
We can extend 10 to 15 minutes if Ginger is okay. Then we are good to go.
That's fine. I can do that.
Thank you, Ginger, for this. Dr. Ashwin, please go.
No, sir. Exactly. I was going to ask how she stores her Afrezza while traveling. I wanted to know.
So I don't worry about making sure it's refrigerator temperature while traveling, the same way I don't worry about my injectable insulin. I carry it in this, and any insulin can really be at room temperature for several weeks, as long as you're protecting it from severe cold and hot temperatures. So I usually always have this with me wherever I go. And then if I'm traveling for a number of days, I'll pack several of these so that I have backup and extra backup. Because as a type 1, you should never travel without extra of the extra, right? Just in case.
Thank you. I guess we have problem with that in India. Right now, the temperature is soaring about 35 or 40. So I guess
in Ahmedabad, it is 45 degree temperature.
Okay. So we cannot store it like ginger, but we'll find our own place.
Yeah. And we have one more question on Facebook Live, that any long-term chances of malignancy, particularly lung cancers?
I can speak to this because I've had to write about it. It's been studied for risk of lung cancer, and the only 2 people in the study that developed lung cancer were longtime smokers. So there were thousands of people in this study. The only 2 who developed lung cancer were smokers. So I'd highly recommend you quit smoking.
Right. Great message. So wonderful. Before we go ahead, actually, I would like to read her biography that we forgot. That Ginger is herself is author, writer, and a speaker, and she is associate director of communications at T1D Exchange. And she has many books that she has published, like recent, it was Exercise with Type 1 Diabetes. The children's book is Ain't Gonna Hide My Type 1 Diabetes. When I Go Low, it is also for children. And other book is Pregnancy with Type 1 Diabetes. I'm very much interested. Your Diabetes Science Experiment, then Emotional Eating with Diabetes. And the most important book, I would say, is Dealing with Diabetes Burnout. And you can now integrate it with Afrezza as well.
Thank you for sharing all of that.
Yeah.
So before I close it up, and I just want to have one quick comment or say advice for our audience, and to take home message for our audience from all of our panelists. I would like to begin with Dr. Anushri.
So thank you, Dr. Rutul. I think this was a wonderful initiative. Ginger, I'm very, very impressed with your profile and the way you spoke today. You cleared our doubts, and your understanding of diabetes is phenomenal. So I would like to really mention that. What I would like to tell our viewers is that medical science is evolving rapidly. There are new molecules coming in every now and then. So please be in touch with your healthcare professionals. Otherwise, you will miss the opportunity, because we see a lot of patients who come and then come back after 10 years and they're still using a 10-year-old treatment whereas the world has moved forward, So yes, please be in touch with your healthcare professional to take advantage of the opportunity.
Wonderful. Dr. Ashwin?
Yes, sir. It's a wonderful learning curve for all of us too. And I would say, yes, we are lagging almost 10 years behind US, I feel. Since I was listening her comments on Libre and Dexcom and all, they started using 10 years back, which is currently in use in India. For our viewers, yes, this is a new new kid in the block. Definitely, we have to try this and share our experience in Indian patients too. We have to see if it works in India in our setup. Thank you, sir.
Thank you. Dr. Amit?
In our country, most patients have a huge inertia of starting insulin therapy. And I think that inertia comes from both the clinician side as well as the patient side. So if you can have accessibility to an insulin which you can inhale without any prick, I think it's going to go a long way in taking away that inertia. But at the same time, 2 things are very important, which I've learned from today's session, especially from Ginger's experience, is that it will require very, very close monitoring, both from the patient side and very close guidance from the healthcare provider side. And also very good understanding of what you're eating. That's going to be very, very important for the patients. So very good patient education will be required in the future when we are initiating our patients on inhaled insulin, because they should understand that how quickly this molecule is going to act, how they can take the corrected bolus, and how they should, space their meals. So those are my understanding and learnings from the session.
Wonderful, Dr. Amit. Dr. Dhruvi?
So, first of all, yet again, another successful and amazing program by the D Genius Group. We're very thankful for our special guest, Ginger. It was amazing listening from you about all your first-hand experiences. We are all together in this. For all the people with diabetes who are listening to us, we are all with you. Talk about diabetes, learn about diabetes, ask questions, don't hesitate to put forward your queries. We are all here and we are all together in this. That's my message to everybody listening. Anybody and everybody from the D Genius platform and outside as well, we are all here to help you.
Great. Dr. Rutul?
Yeah, I guess everything is said and already done. But I would say that you please go through book of Ginger's. So as I was going through all the books as on Amazon, and I really would say that if you really are interested in type 1 diabetes especially, then you should go through, because patient experience is more important than doctor's own experience. As we spend a very little time with patient, and patients spend more time with themselves. This is why you should listen to patient more in type 1 diabetes. And definitely, I'm looking forward for Afrezza to be launched in India. And thank you very much, Ginger, again for getting time for us. Thank you very much again.
Thank you. And Ginger, would you like to give a message to our Indian audience here?
Sure. I would definitely, first of all, recommend that you quit smoking if you don't want lung cancer. And secondly, don't be afraid to just keep learning about new things. I am only thriving with type 1 diabetes because I never stopped trying to understand it better. So the more you learn, the bigger and better your life will be.
Thank you. And
we've had a fantastic moderator, Dr. Bharat Sabu, who's yet to give his opinion and his message.
No. I just want to tell Ginger that today you will be getting thousands of new followers. Take my words. You have been so popular in India today. And it's really inspiring how you have lived your diabetes. Lived your diabetes is the way actually to move forward with diabetes. And every patient at least should follow Ginger, the way she is educated herself towards type 1 diabetes and the way she is managing it. It's really commendable. So word of a hand of applause for Ginger today.
Thank you. You can find me on Instagram if you'd like more diabetes.
That's why I told you will get thousands of new followers. I have already seen it.
Thank you.
Thank you. And I would like to thank all our panelists who have given their valuable time. Of course, Ginger, who has taken a time out for our Indian audience to make us aware about this new kid in the block, which seems so exciting. I think 1 hour is a less time for this molecule. We will meet surely again. And I'd also like to thank Dr. Banshi Sabu for taking his time out and joining us. So again, thanking everyone and thanking the audience, which actually poured in with questions. They have showered their questions on us. And it was a really exciting and enterprising session. Thank you again, everyone. Thank you. We will meet again soon. Thank you.
Thank you. Bye-bye.
Bye. Good night.